So now we'll move on with the expiration. Okay, so in expiration what happens? Only during the forceful expiration, that is during the exercise, it is controlled by the ventral respiratory group. Okay, but then at rest, okay, it is a passive process, you know, right? Because lung is a spring. Okay, so there is no neuronal control. Only when there is forceful expiration, that is during exercise like condition, then it is controlled by the ventral respiratory group. Okay, now we will move on with some lesions. Okay, so what are the lesions we will see now? So there are three conditions. Okay, so first the lesion below the medulla. So what are the things that are present below medulla? You already know, that is VRG, we have DRG. But above VRG, that is ventral respiratory group, we are having our initiator, the pacemaker, that is the pre-Botzinger complex. That will not come into role. So what is going to happen? Our pre-Botzinger complex cannot activate our spinal cord. What happens? There is no initiation of inspiration because pre-Botzinger complex is our pacemaker of neuron, right? So there will be no initiation of inspiration. But then, if the pre-Botzinger complex is absent, remember, in a patient where the pre-Botzinger complex is absent, then what happens? The respiration becomes voluntary process. Then think about when they sleep. Okay, when it's a voluntary process, when they sleep, what happens? They may die. Okay, so the respiration stops and that leads to death. Okay, so that condition is called as Ondine's curse. Understand? Ondine's curse. Now what's the treatment we can give? Mechanical ventilation. Okay, now the next part of lesion, where the lesion is at pontomedullary junction, then what happens here? Remember, for pons it will regularize the respiration, right? And for medulla it will initiate our respiration. So what happens? There will be irregular respiration. So lesion at the pontomedullary junction, there will be irregular respiration. Okay, now lesion in the mid pons, when the vagus is cut, what happens? See, pons, if you see, it is divided into two parts. One is upper pons and lower pons. Upper pons, if you see, we have the pneumotaxic center, and lower pons you have the apnosic center. Now what happens here? See, when this apnosic center will not be inhibited, but then it is activated, which means what happens? There will be prolonged inspiration. Okay, there is prolonged inspiration that causes apnosis. Very important. Very important 1 mark question they can ask you. Okay, now you just revise what are the conditions. So lesion at below medulla, then what happens? The respiration will stop. The respiration will become a voluntary process if it is absent, the pre-Botzinger complex. Okay, then we need mechanical ventilation. That death is called as Ondine's curse. When the lesion is at pontomedullary junction, then what happens, sir? Irregular respiration. If the lesion is at mid pons with vagus cut, the apnostic center will not be inhibited but then activated, that causes prolonged inspiration, that is called as apnosis. Right, very simple. Next we will move on with the pulmonary reflexes. So there are different reflexes what is happening in our body. The first important thing is Herring-Brewer reflex. Okay, so it is a protective reflex which is present in our body. So here it's a very important 5 mark question. Okay, please understand the concept is very simple. We have two different types, that is Herring-Brewer inflation reflex and Herring-Brewer deflation reflex. Now Herring-Brewer inflation reflex nothing but when there is prolonged inspiration, the patient is having prolonged inspiration, remember the inspiration will be inhibited. So what, see, a patient is having prolonged inspiration, okay, then what this reflex will do, it will inhibit, the inspiration is inhibited, the duration of the inspiration will decrease and duration of the expiration will increase. Very simple, right? And we are having deflation reflex. This is opposite. When the patient is having prolonged expiration, the expiration is inhibited, the duration of the expiration will decrease and duration of inspiration will increase. Very simple, right? And it is mediated by slow adapting myelinated vagal fibers. You have to remember this. Slow adapting myelinated vagal fibers. Very simple, right? Next important thing, Head's paradoxical reflex. What is this? It is just opposite to Herring-Brewer reflex. Listen carefully. When there is prolonged inspiration, there will be increased further inspiration. So what will happen in this case? There is prolonged inspiration, the inspiration will be inhibited. But in this case, there is prolonged inspiration, there will be furthermore increase in the inspiration, right? So this occurs once in lifetime, okay, in newborn baby. This concept, let me write here. So in baby in the mother's womb, the lung is filled with fluid, okay. When the baby comes out, okay, this fluid must be filled with air, okay, air, okay. So when the baby comes out, this fluid must be filled with air. That is, during the first breath there will be prolonged inspiration, furthermore inspiration, and here this is the case. So occurs in the newborn with the first breath to replace all the fluid in lungs with the air. Very simple, right? This concept you have to know, right? Next important thing, we have the J reflex. Listen carefully. So J reflex is in condition of pulmonary edema. Okay, pulmonary edema. So the main symptom what the patient comes with is breathlessness. Okay, so we are having different receptors for this. This receptors is present in the juxtaposition of the pulmonary capillaries, that is called as J receptors. Understand? Now in pulmonary edema, the fluid will extravasate from the pulmonary capillary and they are going to stimulate the J receptors. When stimulation of J receptors is done, then you get apnea, breathlessness, hypotension as well as bradycardia. Understand? Very simple, okay. And this reflex is mediated through unmyelinated C vagal fibers. This you have to know now. Now we are having different breathing patterns. What are they? Very simple. Cane-Stokes breathing. Okay, listen carefully. When there is gradual hyperapnea, this is gradual hyperapnea. Okay, there will be carbon dioxide washout, followed by gradual hypopnea. Then you are having apnea, where the carbon dioxide will build up. Very simple, right? So gradual hyperapnea followed by gradual hypopnea and then an apnea. What are the sequence? The carbon dioxide is washed out and here the carbon dioxide build up. So where all you will see, sir, by doing sleep. Okay. Next, congestive cardiac failure and also in uremia. Understand? Next, Biot's breathing. It's called as ataxic breathing pattern. So there is a hyperapnea followed by apnea. Where you will see, sir, when there is a damage to medulla, meningitis condition, you can see this Biot's breathing. Understand? Next, Kussmaul's breathing. So where all you have heard this Kussmaul breathing? In diabetic ketoacidosis, right? Very simple. So there is hyperventilation and also there is increase in the rate as well as depth of the respiration, that you have to know. Next, prolonged inspiratory spasm, also called as apnosis. You will get like this pattern. Okay, so when there is damage in the midpoints with vagus cut. So these are all the conditions and these are all the altered breathing patterns. So we have completed with the neural regulation of the respiration. If you have any doubts, you can ask me. And if you have any kind of queries or any kind of difficulties in understanding, then you can follow me on Instagram and message me. Thank you. Have a nice day and don't forget to subscribe. Thank you.